So hello and welcome to episode 6 of the Surgical Discussions podcast with Johnny and Ed. My name is Ed.
And my name's Johnny.
And in this podcast we're going to introduce lower GI surgery. So we're going to look at some basic lower GI anatomy, particularly the anatomy of the small intestine and the large intestine. And then we're going to talk about one of the most important gastrointestinal presentations, which is obstruction.
Mm-hmm.
Okay? So, Johnny's going to start talking about the anatomy.
So we're going to talk about the duodenum, which is C-shaped and about 25 centimetres.
Yep.
It's divided into 4 sections, D1 to 4.
Yep.
So D1 is the transverse part, the outflow from the stomach.
Yep.
D2 is the curved section.
Yep. Which wraps around the head of the pancreas.
Yep.
Yep.
Where the pancreatic duct enters.
Yep.
D3, which is...
It's the horizontal bit as it comes down around the head of the pancreas. It then goes horizontal again. And then finally D4, which is where it goes up, as you can see in the picture, and then at the duodenojejunal junction becomes the jejunum. Important relations, or some of them are shown quite nicely on this diagram. Posterior to D1, we have the common bile duct, and also, importantly, the gastroduodenal artery, which may, in fact, be damaged with an eroding duodenal ulcer, specifically a posterior eroding duodenal ulcer. In D2, the most important structure, of course, is the duodenal papilla, where the ampulla of Vater comes out into this part of the duodenum. D3, the horizontal bit again, anterior to D3, you find the superior mesenteric artery and the superior mesenteric vein. In terms of the blood supply of the duodenum, it's quite easy. D1 and D2 is supplied by the superior pancreatico-duodenal artery, which is a branch of the gastroduodenal artery. And D3 to D4 is supplied by the inferior pancreatico-duodenal artery, which is a branch of the superior mesenteric artery. And that's easy to remember if you remember the important relations, both in D1 and D3. So, the small intestine. Small intestine is about 6.5 metres average in length. And you can actually afford to lose about 50% of this and still have a functioning bowel. We split it 50-50 into jejunum and ileum. And the important features to notice, or the important differences between these, are first of all the location. So the jejunum tends to be in a more umbilical location, while the ileum is more hypogastric and pelvic. The jejunum tends to be wider bore, while the ileum is thinner bore. The jejunum tends to have a thicker wall than the ileum. And finally, the jejunum tends to have fewer arterial arcades supplying each section of bowel compared to the ileum. So those are some basic differences.
Good.
Okay. So, I think Johnny's going to talk a little bit now.
Okay, so the large intestine is approximately 1.5 metres, and it starts at the cecum,
Yep.
Where there's the appendix, which we'll talk about later in the next podcast.
Yeah, when we talk about appendicitis.
Mm-hmm. And then there's the ascending colon, which goes up to the hepatic flexure, and then transverse colon across to the splenic flexure, descending colon, sigmoid colon, and then the rectum and anus. So
Easy stuff.
Yeah, should know it already.
Yeah.
So the ascending and descending colon have no peritoneum attached. They're attached to the posterior wall, whereas the transverse and the sigmoid have peritoneum attached.
Yep.
And the cecum is variable depending on person to person variation. The top third of the rectum is retroperitoneal, and the bottom is completely peritoneal.
And the middle third is 50-50.
Yeah.
Okay.
It changes as you go down.
Mm-hmm.
Blood supply of the lower GI tract, you can split it into the foregut, which is stomach and half the duodenum, to the duodenal papilla, which is in D2, and that's supplied by the celiac axis, which is at level of T12.
Yep.
Then you've got the midgut, which is from the duodenal papilla to the distal transverse colon, near the splenic flexure, and that's all supplied by the superior mesenteric artery.
Yep.
And then you've got the hindgut, which is the distal colon, distal transverse colon onwards towards the rectum, which is supplied by the inferior mesenteric artery.
Yeah, okay. And there's a particular important point here about the splenic flexure, isn't there? That this area around the splenic flexure,
the watershed area?
Watershed zone, yeah. It's got a very poor blood supply. Venous supply, as with the arteries, there are two major mesenteric veins, the superior mesenteric vein and the inferior mesenteric vein. The diagram shows the venous supply quite well. The inferior mesenteric vein comes up and drains into the splenic vein, which is part of that large trunk of vessels passing laterally. And then it joins the superior mesenteric vein to form the hepatic portal vein, which of course then goes off to the liver. But the diagram, I think, shows that quite well. Lymphatic drainage. This broadly corresponds to the blood supply, but on a basic level, there are very small nodes found throughout the bowel, and particularly around the bowel wall, and these drain into large mesenteric nodes, which then drain into even larger nodes on the particular mesenteric vessels, and then finally drain into the cisterna chyli. Of course, as you know, the cisterna chyli then forms the thoracic duct, which goes up and drains into the left subclavian vein.
Mm-hmm.
Aha!
Mm-hmm. Here we go. Intestinal obstruction. So it can be defined as simple, where there's only one obstructing point, and there's no complications with the vascular system.
Mm-hmm.
Or you can have closed loop, which is when you've got two obstructing points, and this gives you the danger of distension and then leading on to perforation. So an example of this is when you've got a left colonic malignancy,
mm-hmm.
and you've got a competent cecal valve.
Yeah, which is in about 20% of people. Isn't it?
Mm-hmm.
Yeah.
And finally, you've got strangulated, where you've got the above and a vascular compromise. Okay. So it may go to ischemia.
Yeah, and that's quite serious, isn't it?
Yeah.
That's a reason to go in there and go after it. Okay, etiological classification. This is a very well-known system, which we're going to talk about. That's the classification of bowel obstruction into mechanical causes and non-mechanical causes. When we think about mechanical causes, just like when we talked about the esophagus, these can be things in the lumen, in the wall, and things from outside. So, in the lumen, there's a couple of things to be aware of. First of all, meconium, in meconium ileus, which, for example, is a fairly common cause of bowel obstruction in patients with cystic fibrosis.
In the neonates.
In neonates, often, yeah. Other things, obviously, impacted feces can do it, foreign bodies, certain types of worms. A gallstone ileus can also do it. If you remember, we mentioned that back in episode 4, or was it 3?
Can't remember.
Probably episode 4. And then finally, an intersusception, where one bit of bowel telescopes over the other bit. That's quite common in kids, isn't it? Yeah. Okay, well, you can have abnormalities with the wall causing bowel obstruction. These can be congenital or acquired. The congenital ones aren't so important, but include atresia, stenosis, and an imperforate anus. The acquired ones, much more common, and the most important types of disease to remember are neoplastic processes and inflammatory processes. Neoplastic things, obviously tumours. This is particularly important in the large bowel.
Yep.
And inflammation, which is more important in the small bowel, such as IBD. But diverticulitis can also cause it. And finally, there are a couple of other ones, trauma, hematomas, but those are not so important at our level. And then lastly, and perhaps most importantly in terms of the contribution that they make to the actual cause, the total number of causes of bowel obstruction, are the things outside the wall. Most importantly, adhesions, but also hernias, volvuli. And those are three very important things to remember. Lastly, anomalous vessels can cause problems, as can abscesses and hematomas. So, non-mechanical.
This is also known as paralytic obstruction. So this is when the bowel is shocked, and it can be shocked either surgically, so post-operatively, where it's paralysed and then you get third space losses and things like that, in peritonitis or ischemia, as we've mentioned before. Or it can be medically shocked with electrolyte imbalances, metabolic disturbances, and certain drugs.
The anticholinergics, particularly.
And finally, you've got pseudo-obstruction, which is Ogilvy's syndrome. So what's this?
This is when you look at your X-ray, or the patient has the features of obstruction. You look at the X-ray, and you can see dilated loops of bowel and all those things that would make you think of an obstruction, but there isn't any obvious point to this obstruction. And usually this occurs in elderly patients who are quite ill, either septic or have electrolyte aberrations.
So it's important not to diagnose obstruction only on the X-ray.
Whole clinical picture, very important. Okay, some practical applications. We've split up the whole subject into mechanical, non-mechanical, but it's important to be aware of the things that most commonly occur in both the small bowel and the large bowel. In the small bowel, you want to think about adhesions or hernias, and in the large bowel, you want to think particularly about neoplastic processes. This is the most common cause of a large bowel obstruction. Also, diverticulitis, not diverticulitis per se, but really stricture secondary to inflammation of the wall and aberrant healing. And then lastly, volvuli, either in the cecum or the sigmoid. Other points, we actually mentioned this already, but in large bowel obstruction, 20% of people have competent ileocecal valves, and these people are at risk because the air doesn't backflow into the small intestine, so it simply expands, and obviously there's a risk of perforation here, causing peritonitis. The most common site of this perforation is the cecum, because this has the thinnest wall.
So, the 4 features of obstruction. Firstly, you get pain, which is central and colicky in nature.
In small bowel obstruction, it's going to be central, isn't it?
Yeah, because as we described, that's where the small bowel is.
Yeah, and also because it's a midgut structure, and pain that's referred from midgut structures goes to the epigastrium. If it was in the large bowel, it might be slightly lower down, because hindgut is causes pain fairly low down.
Okay. Constipation. Often people say absolute constipation, so not only are you not passing feces, but also there's no flatus. Vomiting, which in small bowel obstruction often the onset is earlier. And finally distension, as we've mentioned before, if the air can't backtrack, then builds up
and causes big tummy.
So, on examination, obviously start with inspection and look for things like surgical scars, which can indicate adhesions, hernia, which could be around the scars, such as incisional.
And an excellent way to test for that is to get people to do 2 things. To cough
and just lift their head up.
Lift their head off the bed, and that's quite a snazzy thing to do in the exam.
So palpation, tender, obviously, and if there's strangulation, we mentioned before, then you might get some rebound tenderness or percussion tenderness. And obviously you might see a mass if there's a neoplasm.
Cool.
Percussion, tympanic percussion notes, so that's because there's air in it. It's resonant. Auscultation. If there's small bowel obstruction, you might hear tinkling bowel sounds, which I'm not quite sure how they sound. But
just kind of musical, high-pitched sounds. I think it's because of all the juices and the gases in the small bowel, and the excess peristaltic movement causes all the kind of polyphonic sound. It's tinkling in nature, but I don't know. I just see it that way.
And if there's a paralysis, then there's not going to be any bowel sounds because there's no peristalsis, obviously. Yep. And finally, check all the hernial orifices and do a PR.
Always do a PR. So investigations, we use our standard technique. Cultures, yes, if they're septic, you might want to do blood culture. You might also want to consider doing a urine dipstick. In terms of the bloods, an ABG, yes, if they're unwell. But venous is going to be important here, particularly looking for an infective process and a leukocytosis, also a raised CRP. U's and E's are important because if there's an electrolyte disturbance, this could be causing a non-mechanical. Yeah, non-mechanical. Amylase, because the nature of abdominal complaints to always do an amylase. And if you're thinking about surgery, you want to do a group and save and possibly a cross-match. Imaging studies, it's important to do an erect chest x-ray. And this is looking for, of course, free air under the diaphragm, which would be indicative of a perforation. You then, of course, want to do an abdominal x-ray, looking for the particular features of small and large bowel obstruction. And finally, you can think about doing an enema with gastrographin to get more of an idea about any colonic problems.
Why would we be using gastrographin, Ed?
Gastrographin is a water-soluble contrast agent that's not very toxic. So in the case of a perforation, if it gets into the peritoneal cavity, it won't cause as much irritation as very
Gold star for you.
Gold star. Scopic, biopsy, or functional, probably not. At least not in the initial stage. Aha! Here it is.
So here we see the features of small bowel obstruction. As we mentioned, the small bowel is central, and so you'll see it in the centre of the radiograph, and you'll see lines going all the way across, which are called valvulae conniventes.
They are, yeah.
So those are the two important features of small bowel obstruction.
Absolutely, and that's shown quite clearly, I think, in this slide. Yep, and then here is a large bowel obstruction. You can see dilated bowel in the upper portion of this abdominal radiograph, and the lines aren't going all the way across, just part of the way across, and these are called haustri. And those are really the only important differences to remember. That small bowel obstruction, you've got central bowel, lines going all the way across. Large bowel obstruction is more peripheral, like on this film, and lines not going all the way across. So remember those things. And here's an abdominal x-ray with a gastrographin enema, as we said. So you can see it coming up through the rectum, then around the sigmoid, and then up. And I think there's probably an obstruction around the splenic flexure. But that's just an idea of what one of these things looks like.
So, management. As always, we start with conservative things. So, adequate analgesia, they've got pain. And the most important thing is the drip and suck. So, nil by mouth, and then fluids, and remove anything in the bowel.
Yeah, so you're basically looking to remove stuff in the bowel to decompress it. And then provide fluids because, as we said, you get quite a lot of third spacing. So people can seem quite hypovolemic even though they're not got any obvious source of fluid loss.
And you can also use gastrographin, which irritates the bowel, maybe causing increased peristalsis and removal of the obstruction, possibly.
But doesn't irritate it a lot, not as much as barium.
No. Okay, so you do that for about a day and look for signs of resolution, so clinical signs resolving or resolution on the abdominal x-ray.
Yeah. And also you can manage these things surgically. The most important indications for surgical management of a mechanical bowel obstruction are for simple obstructions, neoplastic processes or failure of that conservative strategy. So if you've done your drip and your suck and you've given your gastrographin and they're not resolving within 24 hours, you really might need to think about going to surgery. In closed-loop obstructions, you also might want to do it. So, for example, with that colonic tumour and a competent ileocecal valve, or perhaps in the case of a volvulus. And then finally, obviously, if there's strangulation or perforation, then you need to get in there pretty quickly. In terms of non-mechanical things, obviously you want to prevent these things happening. So you reduce bowel handling, peritoneal lavage, things like that. In In terms of the conservative management, once again, you need to give analgesia, you need to drip and suck. And then medical management, you really want to treat the cause. So if there's an electrolyte aberration, then you want to correct this, and hopefully then the non-mechanical thing will resolve. So that really completes this podcast. In summary, we've looked at the important anatomy of the duodenum, the small bowel, and the large bowel. We've looked at different types of obstructions and how you classify them. We've looked at the 4 very important clinical features of bowel obstruction. We've looked at some investigative strategies, and we talked about the important ways to distinguish small and large bowel obstruction on an abdominal radiograph. And finally, we've looked at some of the surgical and non-surgical management principles. So thanks for listening. We'll see you at the next one, hopefully. It's goodbye from Ed.
And goodbye from Johnny.
Bye. Bye.
Sorry, I've just had a brain pain. Continue.
Okay, fine.